So hello and welcome to episode 11 of the Surgical Discussions podcast series with Johnny and Ed. My name is Ed.
And my name's Johnny.
And during this podcast, we're going to have a look at lumps in the neck. Specifically, we're going to consider the anatomy of the neck and the thyroid. We're then going to look at different sorts of neck lumps, have a look at lymphadenopathy, consider solitary lumps, parotid lumps, and lumps in other salivary glands, and finally talk a little bit about surgical aspects of thyroid disease. So, neck and the thyroid anatomy. You can basically divide up the neck into an anterior triangle and a posterior triangle. The borders are commonly asked about in exams, and the superior border of the anterior triangle is made up of the mandible, posterior, the anterior bit of sternocleidomastoid, and the furthest front and the front bit with the midline. The posterior triangle, the borders here are the posterior part of sternocleidomastoid, the clavicle, and the anterior part of trapezius. You can subdivide the anterior triangle into submandibular portion, submental portion, carotid portion, and the muscular portion. The submandibular and submental areas are found underneath the chin. The carotid area, as you'd expect, contains the carotid vessel and is therefore pulsatile, and the muscular part is in the midline and composed mainly of small muscles. In terms of the lymphatic drainage areas, there are a number to be aware of, and they're marked clearly on this diagram. As we said, two important parts of the anterior triangle are the submental and submandibular regions, and these are shown here. Two is jugulo-digastric. This is very commonly involved in episodes of tonsillitis, and is probably the most common cause of a swollen gland in the neck. Three is the middle jugular nodes. Four, the inferior jugular nodes. And these together form part of the anterior nodes. Five is the posterior triangle nodes, and six is marked as the front line or the midline anterior compartment group. Here's a bit of surface anatomy, just to remind you where to feel for an examination. I often find it's easier to start at the first area shown here, submental region, and then work round as it's shown here. So just going through them, number one is the submental, two, submandibular, three, jugulo-digastric, four, preauricular, five, postauricular, six, occipital, seven shows the important anterior nodes, eight shows the supraclavicular nodes, and nine, the posterior group. So just remember that diagram and try and go through those when you're feeling for lymphadenopathy and other glands in the neck. Okay, just to talk quickly about thyroid anatomy as promised. The thyroid is found embedded in the pretracheal fascia and overlies the second to the fourth tracheal rings. Important relations, anteriorly you'll find the strap muscles.
And what muscles are they, Ed?
There are lots of these small, I don't know what they are. Do you know what they are?
I can't remember for the life of me. But okay.
They're called strap muscles, group of midline muscles. I'm not sure. We need to know about that.
Okay.
Posteriorly, you'll find the parathyroid glands, larynx and trachea, and of course the laryngeal nerves. And it's important to remember the recurrent laryngeal nerve, but one that often people miss out mentioning is the superior laryngeal nerve, which is also found posteriorly to the thyroid. Thyroid is in three parts. The major part is the lateral lobes. This consists the majority of the mass of the thyroid, and these are joined by an isthmus, which is found between the second and third rings of the trachea. And then there's a variable and inconsistent pyramidal lobe that's sometimes present. So here is a drawing of the surface anatomy, or the important surface anatomy of the thyroid gland and the associated cartilages. The hyoid bone is found at about a level of C3. The top of the thyroid cartilage at about C4. and the thyroid gland shown here between the second and fourth tracheal spaces. Also notice the suprasternal notch as well marked on the diagram. Okay, so as we've already said, the thyroid is divided into three important bits: the lobes, so left and right lobes, the isthmus joining them in the center, and then an inconsistent pyramidal lobe. Also note on this diagram that the superior thyroid cartilage is marked, the inferior cricoid, and inferior to that, the cricoid cartilage is marked, and also note the recurrent laryngeal nerve noted on this diagram as well. In terms of the blood supply to the thyroid, there are two important thyroid arteries. These are the superior thyroid artery and the inferior thyroid artery. The superior thyroid artery is a branch of the external carotid, and the inferior is a branch of the subclavian. In terms of the venous drainage, there are three important veins. These are the superior, middle, and inferior. The superior and the middle drain to the internal jugular, and the inferior to the brachiocephalic. In terms of lymph drainage of the thyroid, most lymph drainage occurs to the middle jugular nodes, but remember, it may go anywhere, and this is particularly true for some of the more aggressive thyroid cancers. I'm going to move on now to talk a little bit about the salivary glands. There are three important salivary glands to be aware of. These are the sublingual, submaxillary, and the parotid. The parotid is the largest and has a very important posterior relation, which is the facial nerve, or seventh cranial nerve. Here's a little diagram just showing the important locations of these glands and the drainage points. You can see the parotid gland there draining into a point in the upper mouth above the second molar. You can also see the submandibular salivary glands and the sublingual salivary glands. So we're going to go through each of the glands in turn. The submandibular gland lies above the digastric muscle. It's split into superficial and deep portions by a muscle called mylohyoid. It drains via Wharton's duct into small caruncles called the sublingual caruncles, which are found either side of the sublingual frenulum. There's a dual innervation from both parasympathetic and sympathetic. However, the sympathetic innervation is to the blood supply and therefore has its action on salivary secretions indirectly. The parotid gland, as we said, is the largest of the salivary glands and resembles a three-sided pyramid with the apex directed downwards. It lies over the mandibular ramus, which is found anterior and inferior to the ear. As already mentioned, important relations are the facial nerve. However, another important relation is the external carotid artery that bifurcates into the maxillary and superficial temporal close to the gland. Stenson's duct drains to the upper second molar at a point called the parotid papilla on each side. Finally, the sublingual gland, which is the smallest gland, lies anterior to the submandibular gland and drains via the sublingual duct of Bartholin to join the submandibular duct at the sublingual caruncles.
So that was a bit dry. Let's move
Very
on to,
dry. Yeah, very dry.
Something a bit better, hopefully. So let's talk about lymphadenopathy, which is obviously fairly common, and it's just the enlargement of lymph nodes. We can divide this into localized, so solitary lymph node enlargement, or generalized, including different groups.
Yep.
Localized can then be split into infective causes, which can then again be split further into acute or chronic, and primary or secondary. Mm-hmm. And then they can also be caused by neoplasia. And once again, this can be from a primary malignancy or metastases.
Yeah, and a primary infection of a lymph node is termed lymphadenitis. Another name for that.
Okay. And generalized, once again, infective causes, so acute mononucleosis, or chronic things like HIV or syphilis.
Yeah.
You can also get neoplasia, causing a generalized lymphadenopathy, things like lymphoma, Hodgkin's or non-Hodgkin's type, and chronic leukemia.
Yeah. And sarcoid.
And also sarcoid, as it can do pretty much everything.
Yeah. Like syphilis.
Much like syphilis. Okay, so when thinking about a neck lump, obviously the most important things are a good history and an examination, but then you've got to think about investigations. So once again, we'll go through our normal way of thinking about investigations.
I think, yeah, the investigative sieve. Maybe we could call it that. There's a surgical sieve.
Okay, investigative sieve.
It's a bit of a tongue twister.
Yeah. Okay, so cultures possibly, if you're thinking of an infective cause.
Yeah.
But then onto bloods, so you do a full blood count, a CRP for any inflammatory markers, TFTs, LFTs, a blood film for any lymphoma or leukemia.
Yep.
And also serological tests for infective causes.
Yeah, like
HIV.
monospot, maybe.
For TB?
No, monospots for mononucleosis.
What's the TB one? Ellie spot.
Is that Ellie spot?
Ellie spot for TB.
Okay.
Also imaging, so chest X-ray and a CT.
Yeah.
And biopsy or endoscopic tests, so a fine needle aspiration cytology or a two-cut core biopsy.
Yep.
So, talking about solitary lumps, normally this can be lymph nodes, as we've already discussed, but you can also divide that lumps in the neck into those in the anterior triangle, which we've already said is in front of the sternocleidomastoid, and posterior behind the sternocleidomastoid. So those in the anterior triangle can be pulsatile, non-pulsatile, or submandibular. And pulsatile lumps, they can be normal, so it can just be a tortuous or enlarged carotid artery.
Yeah.
Can be a carotid aneurysm, which I think is mentioned in the vascular.
It might be. There is a talk on aneurysms.
Okay, and we're going to talk about carotid body tumour, which is a chemodectoma.
I prefer carotid body tumour.
Yeah, lets you know what you talk about. So it's a tumour of the chemoreceptor cells, and it's normally benign in behaviour and progressively enlarges. It's more common in middle age, so about 40 to 60 years, and there's a familial tendency.
Cool.
It normally presents in the anterior edge of the sternocleidomastoid, a visible swelling at the level of the hyoid bone. It tends to be hard and elastic in consistency, and it can move side to side.
Okay.
So it can be investigated with an ultrasound or angiography.
There's a nice angiography there.
Yep. And treatment is excision.
Yeah. And possibly graft.
Maybe.
Yeah.
So non-pulsatile lumps, those in the midline, so thyroglossal cysts, which tend to be around the hyoid bone and move up with the protrusion of the tongue.
Classic.
Dermoid cysts and ectopic thyroid tissue. Other non-pulsatile lumps are those not found in the midline, so a branchial cyst, pharyngeal pouch, or laryngocele.
Cool.
So a branchial cyst, this formed due to an embryological remnant of the second pharyngeal cleft. This is in embryology. You can remember that far back?
I've never even learnt it, I don't think. It's too complicated for me.
Well, maybe you should go back to that later on.
I think I probably should review it.
Okay, anyway, so it's found in the upper two-thirds of the anterior sternomastoid, and usually presents in early adulthood with a soft swelling, which transilluminates. It can often be found after an upper respiratory tract infection. So investigating, most important thing is a needle aspiration which will show cholesterol crystals inside the cyst. And treatment, once again, is excision. You can see a little picture of a branchial cyst here.
Yep,
in
on
the
upper two-thirds of
upper two-thirds.
sternocleidomastoid.
Yeah.
It looks quite cystic, actually, I think.
Yeah.
Not sure how something can look cystic, but it just does.
Okay, pharyngeal pouch. This is a mucosal protrusion between two parts of the inferior laryngeal constrictor.
Yeah.
Yeah?
One of those muscles, I think. Don't know. Complicated muscle.
Complicated.
Yeah.
Okay, so it's commonly found in elderly patients and it's usually on the left. Don't know why that is, but
Maybe there's a congenital weakness inherent in all of us.
perhaps. Okay, so it's in elderly patients, usually on the left, and it's a lump that increases in size when you're swallowing. So symptoms you get are things like dysphagia, which we've spoken about previously, foul regurgitation into the mouth, so maybe a smell, and also aspiration, possibly into pneumonia if it's in elderly.
Yeah, could be.
And here you can see investigation of a pharyngeal pouch. So as we spoke about in dysphagia, a barium swallow, and you can see a nice pouch there.
It is a nice pouch.
I don't know how you rate how nice a pouch is, but
Well, it's not a marsupial pouch. That's pretty much the gold standard, isn't it?
Yeah. Interesting fact.
Yeah.
Kangaroos, 3 vaginas, 2 uteruses. Uteri. Okay, anyway, so they're treated once again with excision or cricopharyngeal myotomy.
Yeah, because it's a muscle problem, isn't it? Well,
Yeah.
defect muscle problem, yeah.
And finally, submandibular lumps. Once again, these are usually adenopathies from infections, so secondary to infection, throat infections, especially with children.
Leading to a jugulo-digastric adenopathy, most common site.
But other causes can be tumours, so lymphoma or tongue secondary, especially in smokers, or impacted salivary stones, which tend to present with pain and swelling after a meal. Pain after a meal, so swelling after a meal, I suppose.
I would have thought so.
Yeah.
Things go together often.
So these are investigated with an X-ray or a silogram.
Or both.
And here you can see an X-ray showing a stone, but it's important to remember that 80% are going to be radio opaque.
And that's the kind of situation when you might need the silogram.
Mm-hmm. Okay, do you want to talk about
I'll talk about posterior triangle. Once again, in the posterior triangle, the most common swellings you're going to find are going to be lymph nodes. So remember the features of localized and generalized lymphadenopathy from earlier. However, in exams, often you'll get other ones. And the important ones we're going to consider here are cervical ribs, cystic hygromas, but just keep in the back of your mind pulsatile posterior triangle masses such as a subclavian artery aneurysm. So, cervical rib, this is an enlarged costal element, usually from the C7 vertebrae. It's quite common actually, about 1 in 150 people are affected. However, only 10% of these will have symptoms. There are a number of problems that these people develop, and they're really due to 2 kind of underlying pathophysiological processes. The vascular syndromes tend to result because of compression of the subclavian artery and vein, leading to thrombosis, Raynaud's phenomenon, and often claudication within the arm. Neurological phenomenon result from pressure on the brachial plexus, which is made up of nerve roots from C5 to T1. This leads to varying degrees of paresthesia and weakness within the hand particularly. Okay, cystic hygromas. A nice picture of a cystic hygroma there, and that illustrates that these are often first noticed at birth, and they correspond with a collection of lymphatic cysts behind the clavicle. They're treated either with hypertonic saline, which can sclerose the different cysts, and can be treated with excision. Okay, parotid lumps. First of all, let's classify parotid lumps. Swellings in this area can either be of the whole gland or localized. Swellings of the whole gland are particularly associated with mumps, sarcoid as part of the uveo-parotid syndrome, where there's anterior uveitis and whole swelling of the parotid gland. And this can often be a presentation, actually, of sarcoid. Chronic liver disease, and also in Sjogren's disease. Localized swellings are usually neoplastic, but can rarely be caused by stones. Okay, in terms of the pathology of the neoplasms that affect the parotid gland, they can be primary or secondary. Important secondary ones would be from lymphoma and other metastases. The most common, however, is a primary benign or pleomorphic adenoma. However, be aware that you can also have an adenolymphoma, which is also benign. You can also have fairly low-grade malignant primary tumours or mucoepidermoid tumours, and high-grade, either an adenocarcinoma or a pleomorphic adenomorphic adenoma. However, this is all fairly fine print stuff, really. Mm-hmm. The pleomorphic adenoma is the one you want to try and remember. Okay, so here's a chap who obviously has some swelling in his parotid on the left side and associated left-sided facial palsy. If you notice, the corner of his mouth on the left is drooping considerably, and if we were to look at his eyes, we would probably see a degree of eye closure as well. So, investigations and treatment. We're not going to go through the surgical investigative sieve here, but obviously you'd want to do those kind of investigations as well. But the most important thing to do is to do a fine needle aspiration and possibly a CT scan for staging. In terms of treatment, you can do a superficial parotidectomy or a radical parotidectomy and or radiotherapy. The most important complication, and this is particularly the case with a radical parotidectomy, is the development of a permanent or chronic facial palsy. There's also a specific syndrome associated with this procedure called Frey's syndrome, which is when you get gustatory swelling. Okay, covered quite a lot of stuff there.
Yeah, time to share a pint.
It does look like we are sharing that pint, doesn't it?
We were sharing that pint.
Were we?
Alternate sips.
Really? I'm not sure I'm comfortable with
Okay.
that. Little interlude.
Yeah. Little break. Little nap.
Enjoy this music. Right. After that short interlude, we're going to talk a little bit about thyroid surgery. Well, Johnny is. I'm going to listen.
You just relax for a bit.
Yeah.
Okay, we're
not too much detail though.
No, because it's mainly covered in medicine.
Yeah.
Treatment of thyroid lumps. So here we go. Once again, when you're evaluating a lump that you think will be a thyroid lump, you must take a good history about the type of lump that it is, the thyroid status, was it a euthyroid, hypothyroid, or hyperthyroid?
Yeah, we're not going to remind you of that stuff.
No, you should know that. Good examination, which you once again can see in a video or look up in a book.
Might put one on the site, actually.
Yeah. And we'll talk about investigation?
Yeah, I think we might, yeah.
Okay. So here it is. So cultures, not really necessary in this instance.
I don't think so.
Venous bloods, obviously you'd be looking for thyroid function, thyroid status, so you'd be doing your T4, your TSH, and any autoantibodies. And then you'd think about any other bloods that are necessary.
Yeah. So looking for like malignant stuff, really, wouldn't it?
Mm-hmm. Okay. Imaging, chest X-ray, and thoracic inlet.
Yeah, thoracic inlet view to see if the thyroid is extending down.
Okay. Ultrasound to see whether the lump is a solid or a cystic lump. Mm-hmm. And then you think about special tests. So aspiration cytology, true cut biopsies, can do radioisotope scans, see whether it's hot or cold.
Yep.
And you can do laryngoscopy. pre-op.
Yeah, that's important because often patients with thyroid enlargements will have involvement of the recurrent laryngeal nerve, but will be asymptomatic, and it's important to know if they have involvement before surgery. And you can do that by visualising the cords themselves.
I can.
Yeah. Well, you probably can't, but thyroid surgeon can.
Okay, so we're going to split thyroid disease into congenital and acquired. And then acquired, we're going to split further into whether it's simple, whether it's toxic, or whether it's inflammatory in cause.
Yeah.
So congenital things is a lingual thyroid. This is when there's a residual tissue at the base of the tongue, and you can see when you're investigating the mouth when you're doing your neck examination. There's also the thyroglossal cyst, which is another residual tissue, so a remnant of thyroid tissue. This is found in the midline, and it's a cystic mass, which is smooth, and it moves upwards with swallowing. So when you're getting your patient to swallow that bit of water in your thyroid exam, you see it move up.
And it would also move up on protrusion of the tongue.
That's true.
Because it's still connected to the base of the tongue.
Okay. And treatment is, once again, excision. So a goiter is any enlargement of the thyroid gland, and as we've said before, we're going to classify it into simple, toxic and inflammatory, and then we're going to classify the goiter as to whether it is smooth or nodular on examination. So simple, smooth goiters are simple goiters, and if it's nodular and simple, then it's just a multinodular goiter. If it's toxic and smooth, then it's most probably Graves' disease, whereas if it's toxic and nodular, then it's going to be a toxic multinodular goiter.
Yeah, and this is usually due to a multinodular goiter having developed a kind of hot node that secretes an excess of thyroxine, leading to a toxic status.
So you'd see it on your radioisotopes.
Yeah, your technetium-99 scan.
Okay. And finally, there's inflammatory goiters, which tend to be smooth. So acute suppurative ductal veins, thyroiditis, Riedl's, and Hashimoto's.
Yeah, we're going to talk about those. Well, you're going to talk about them.
So starting with acute suppurative thyroiditis, this is an infective cause, so either with staph or a strep infection. Then to ductal veins thyroiditis, this is tends to be with a viral infection, so Coxsackie virus, and unlike the staph or strep thyroiditis, this is a non-suppurative thyroiditis. Riedl's thyroiditis, this tends to give you a woody fibrosis. That's a classic thing that's mentioned.
Description. Yeah.
And this comes about due to an infiltration of scar tissue.
Yeah. And it can be associated with retroperitoneal fibrosis as well.
Okay. And finally, there's the one that you learn all about in medicine, Hashimoto's, or autoimmune thyroiditis. So this is lymphatic infiltration of the thyroid gland with antibodies against thyroid globulin. And this means that the patient is firstly hyperthyroid even, and then becomes hypothyroid afterwards.
Yeah.
And this is commonly associated with lymphoma.
Yeah, not the good one for EMQs.
So the thyroid neoplasms. Once again, we split them into those that are benign and those that are malignant. I'm not sure how much you've got to know about this, but we're going to... an example of benign neoplasm is a follicular adenoma.
Yep.
Malignant can be papillary, follicular, medullary, or anaplastic.
Yeah, and there are some important associations which we're going to go through here now. And obviously the details are not important, but you need to know that there are 4 types. You need to know which is the most common, and just remember a few little things about each one. And it's quite easy, actually, if you have a table like this.
Yeah, so we'll just go through the table quickly. Papillary, most common, 70%. Tends to be in younger people. It's multifocal and poor response to radioiodine, so therefore the treatment is surgery.
Yep.
And tends to have a fairly good prognosis.
It's okay. It's not great, but it's all right.
Next most common is follicular neoplasm, and this is about 15%. And this tends to be in the older patients. And this has a good response to radioiodine, so surgery is not as necessary.
No, and an excellent prognosis.
That's good.
Yeah.
Medullary, rare, about 10%, can affect anyone, but it's associated with multiple endocrine neoplasia type 2. So if you think you've come across one of them, then look for the other features.
Exactly.
Needs to be treated with surgery, and prognosis isn't great, but if there's no nodal involvement,
it's fine.
It's okay. Finally, rare anaplastic type.
Bad news, this one.
Poor prognosis, very aggressive in older people. Use radiotherapy to shrink, but as we said, very poor prognosis.
Not good.
Just nice that it's rare.
Yeah, thankfully. Okay, thyroid surgery. The most common indications for thyroid surgery are problem goiters. So that can either be a simple goiter or a multinodular goiter that's actually causing pressure symptoms, such as dysphagia if there's pressure on the esophagus, or shortness of breath if there's pressure on the trachea. The other indication is relapsing hyperfunction, particularly in the case of Graves' disease. And then finally, obviously, malignancy. And as we've said, papillary carcinomas are particularly treated with this. And medullary. No, papillary and medullary. Isn't it?
But remember, papillary is most
common. 70% is that, so it's common. Okay, the procedure that's usually used is a subtotal thyroidectomy. This involves removing 7/8 of the gland, so leaving a little bit of the gland in, and is done using a collar incision. There are some important complications to be aware of. Once again, we can split up complications into immediate, early, and late. Immediate complications can be due, of course, to the general anaesthetic, but specifically to the surgical technique, there is hemorrhage, which may lead to a tension hematoma. This is a surgical emergency and needs to be treated fairly rapidly through draining the hematoma either at the bedside or in theatre. Laryngeal edema is another common side effect, as is nerve damage, particularly to the recurrent laryngeal nerve and the superior laryngeal nerve. Early complications include hypocalcemia due to deficiency of PTH, often because of accidental removal or damage to the parathyroid glands, and infection. Important late complications are obviously hypothyroidism, poor scarring or keloid scarring, and finally recurrence. So here is a nice example of a collar incision scar, one to look out for on inspection of your neck patient.
But quite hard to see as often they put it in the neck folds of patients. Anyway.
Yes.
So you've got to be looking for it specifically.
Yeah, this one's quite obvious because I think it's quite recent, as illustrated by the nice erythema. Erythematous halo.
I like halo.
Yeah. Again. Halo 2 is a bit disappointing. We sound like real geeks now. Anyway, in summary, we've looked at neck and thyroid anatomy, or we've tried to look at neck and thyroid anatomy. It's quite a tricky little area, a bit dry. Lymphadenopathy. Remember that this is the most common cause of a lump in the neck. We've looked at some of the rarer causes, and we split these into anterior and posterior. We split the anterior ones into pulsatile and non-pulsatile. We've looked a little bit at lumps in the parotid. Remember your pleomorphic adenomas and the important posterior relation of the facial nerve. Finally, we've looked at thyroid surgery for problem goiters, for relapse hyperfunctioning Graves' disease, and also for malignancy. So, thanks for listening to the podcast. It's been fun.
Yeah.
Great fun. Difficult subject, but get through it. So until next time, it's goodbye from me, Ed.
And goodbye from Johnny.
Bye-bye.